Hi everyone. I'm going to make a couple of videos on septorhinoplasty or rhinoplasty. I'm Dr. Kusuma from Surya Cosmetic Surgery, now in Weston and also in Boca Raton. And our YouTube channel is called Surya Plastic Surgery. Our Instagram pages, you follow. It's at dr.kusuma or Surya Plastic Surgery or Surya Plastic Surgery and Med Spa. So we have many ways for you to access content, and we're going to post this on YouTube just for your reference. And we share this when patients come and they're getting ready for different types of operations, so you can really understand from my perspective. One of the videos that I made very recently, of course, some of you may have seen it, is about authenticity of content, because in this day of artificial intelligence and a lot of content creativity that is happening with basically computers without hardly any human intervention, it's hard to know authentic information. And so I have decided that I'm going to come on camera. I'm going to do more authentic videos where I'm speaking to you directly and also demonstrating what it is that I'm trying to explain with actual handwriting content, so it looks a bit more authentic to you guys. Okay, that's the word I keep using. So today I'm going to talk about rhinoplasty and septorhinoplasty. There's a difference in the two. Okay, rhinoplasty essentially is an operation that you try to correct some of these things. You try to correct the tip rotation, tip elevation, reduce the size of the tip, or reduce the size of the profile of the nose. Sometimes you have to augment it because they're deficient and they're flat. So all of these various things may have to be done in a rhinoplasty. So for the most part, rhinoplasty is changing the external shape of the nose. The tip, what we call the columella, the width of the base of the nose, the relationship of the base of the nose to the upper lip, the profile of the nose, the width of the nose, hump on the nose, or the profile to reduce it. Sometimes augment it, like I said, because people sometimes don't have support. You have to elevate it. So there's a lot of different external structures that you try to improve. And I did my residency in ENT, ear, nose, and throat, prior to doing full plastic surgery and being involved in full plastic surgery, where I've become very adept at all things face related and neck related. So rhinoplasty and septorhinoplasty and reconstructive portions of the nose have been a big part of my practice for a long time. So with that background is what I'm trying to share this with you. So anytime we do a rhinoplasty, it's also important to consider functional aspects of the nose. Functional aspects of the nose are making sure that you're able to breathe well, so that the nose is not collapsed and it doesn't create any breathing issues, that you don't snore. Perhaps in some cases, if there's any obstruction, there could be noisy. You don't get any nosebleeds. You have nice smooth airflow and symmetry and things like that. So when you do any type of rhinoplasty to change the appearance of the nose, obviously you have to make sure that the function of the nose is also not disrupted, right? So even when you're doing rhinoplasty, you're still thinking of functional aspects of the nose. But for the most part, for the rhinoplasty, you're trying to improve the tip, like I said, the columella, the alar base width, or the width of the nose at the base, the relationship of the nose to the upper lip, the width of the bony part of the nose, the profile improvement, and various such matters. So what is the difference then in a septorhinoplasty? A septorhinoplasty, just for your basic understanding, the nose, if you look at it from the front view, the center part of the nose is where the septum sits, right here across the center part. And the portion here where people have the hump, that's where the septum could be more elevated and you may not have to reduce it, but for the most part it goes from the center all the way down to the base inside the nose. And if that base is crooked, where it deviates to one side or the other, something like that, then you have obstruction of airflow into the nose. And that obstruction can create some physiological changes in the nose that cause the tissues inside the nose to swell up, get engorged with inflammation and swelling, and it's cyclical in nature, goes from one side to the other and causes congestion. And the congestion can further disrupt airflow, that creates further friction and just kind of a vicious cycle. So you have to try to break that. So when people have problems with breathing, you have to try to correct it. If you can identify anatomical structural problems inside the nose, you have to try to correct it. So you try to improve and remove all these obstructions so the septum is nice and straight in the middle. Okay, and then that way the opening is adequate for each person, and therefore the airflow is nice and uniform across both sides. And so a septorhinoplasty involves improvement of the septum. However, one important part to remember is that in rhinoplasty as well, a lot of times when you're trying to improve the nose, you have to use grafting material. Grafting material essentially is structural support things, like that may need to support the tip in a certain way so it doesn't rotate too much, or whatever you want to do with the struts. It's almost like putting foundations in a house or to the roof. So these foundational aspects are cartilage components that you sometimes get from the ear, sometimes you get from the septum, which is what we're talking about. So even though I may not be doing a septorhinoplasty, many times when I do a rhinoplasty, I'll have to work on the septum because I'm trying to harvest that cartilage so I can create better structure for the external appearance of the nose. Again, structure is important not just for the appearance of the nose, it also improves the function of the nose so that it doesn't collapse. So some of you may have noticed, when rhinoplasty used to be done in the 80s, 90s, in that era, it was all reductive rhinoplasty. Essentially, what people tried to do was reduce the size of the tip, make it nice and refined and narrow, and they kind of really removed a lot of the structural support of the nose. And that was called a reductive rhinoplasty. And when that happened after 2, 3, 4 years, the noses started to collapse, where people had very button-looking nose and the sides collapsed, one side collapsed, and they didn't have any structural support, and they suffered from breathing problems for a very long time. So as people started to understand a bit more about the structure, function of the nose and support mechanism, we started doing what we call augmentation or structural rhinoplasty. Structural rhinoplasty, because now you're trying to improve the appearance of the nose, but you're also paying very, very close attention to making sure that the function of the nose is there, and it's going to have the support it needs and won't collapse, because breathing creates a force inside the nose, a negative pressure inside the nose, and that can cause the tissues around it to kind of be sucked in, and you want to resist that because otherwise it clogs you off. And some people say, I just can't breathe from this side of the nose. Every time I breathe in, I feel like there's an obstruction right here or here. So these are functional things that you have to know about. And fortunately for me, because I've had ENT background and training, I was able to really pay attention and respect these functional aspects in addition to the cosmetic aspects of the nose. So that's why I very much focus on these, kind of a very complementary aspects of it. So a septorhinoplasty, very quickly. So this is from a side view, this is the septum. From the front view, the center part is the septum. So all these obstructions have to be removed, and it's called a septoplasty. When people only have problem with breathing and they don't care or bother too much about the appearance, you can just do what we call a septoplasty. Okay? You can also do something called a turbinate reduction. Turbinate reduction. So when you're doing a septorhinoplasty, again for breathing purposes, on the sides of the nose in this area here, there are these structures called turbinates right here. They almost look like fins on the side, and they start like a little ball in the front, and they kind of go back into the nose. And these, when they get engorged, can obviously close off this space where you have to breathe. And when that happens, breathing suffers again. So when we do a septorhinoplasty, many times I reduce the size of these turbinates and move them out to the corners on the inside, so that again the opening is made much wider, so you're able to breathe a whole lot better. So these are functional aspects. So septorhinoplasty is called a functional and cosmetic septorhinoplasty, and that's the terminology used. And when we do this, the septal portion of it or the turbinate portion of it sometimes can be put through insurance if people have that insurance. Unfortunately, I don't accept or take insurance, but in some surgeons who do take insurance, you can try to put that through insurance and see if they cover a portion of the operation perhaps. But generally speaking, rhinoplasty is all out-of-pocket expense because insurance typically doesn't cover it, even though you may have some functional problems with it. So when you speak to your surgeon, make sure you talk about functional aspects of the nose, breathing components of the nose, what can affect it, is it going to affect it or not, if so, how do you prevent it, how are you proactive about it, and things of that nature. Okay. And then when you do a rhinoplasty or a septorhinoplasty, you can do it either open, which means that you'll have incisions in the nose just right here, and the rest of the incisions are inside the nose and sometimes maybe right in the corner here. That's called an open rhinoplasty, where you open up the nose and kind of elevate the skin so you see the structure of the nose, all the bone and all the cartilage, and then you change it, improve it, support it, reduce it, whatever you have to do, and put the skin envelope back together. So that's called an open rhinoplasty or open septorhinoplasty. Sometimes you can even do a closed rhinoplasty, because I saw a patient yesterday who came in who just wanted the hump reduced, nothing else, did not want any other change. In that case, you can make an incision inside the nose and glide under the skin here, and then kind of profile reduction without doing any kind of other incisions on the outside, and you don't have to do a major improvement, because the only purpose is to reduce the profile of the nose, which was minor in nature. So in those cases, you could do what we call a closed rhinoplasty. Some of the older surgeons from the 80s and 70s, maybe they used to do all of it under closed because they were able to do manipulation. But modern surgeons this day and age, I would venture to say that 90% plus of the time, people probably do always open rhinoplasty, because you can really get a good look at everything. You can really do a lot of manipulation. You can augment it the right way. You can position it the right way and get the improvements that you are looking for. So open and closed rhinoplasty. Osteotomy is another term that you may want to know about, because osteotomy essentially means that if there's any width problems or kind of some contour problems, you can actually fracture in a controlled fashion the bones of the nose and move it so that you can narrow the width of the nose very nicely. That's called an osteotomy. Or sometimes people ask, do you have to break the bones? That's in surgical language is called an osteotomy, and that's something sometimes is necessary for the rhinoplasty, septorhinoplasty, depending on the situation. Okay, but typically an osteotomy or breaking the bone does not affect breathing, and it is not. So most of the time when you do an osteotomy, it's almost always for appearance to narrow the width of the nose. Okay, and that bony narrowing does not affect breathing, because most of the breathing goes along the floor of the nose, not up here. Okay, nose actually doesn't go up in this direction, the airway. It actually goes straight back and down. It doesn't go in this fashion. Everybody thinks you breathe this way, but actually you're breathing directly at the floor of the nose, because you're trying to direct that air into the lungs down here. Although the shape of the nose is in this fashion, naturally when people breathe, they feel like it has to go this way. So even when you do nasal sprays, it's not good to spray this fashion. It's actually good to put it this way, so that you direct all of it in the back of the nose towards the mouth. Okay, so that's the osteotomy component. So in addition, sometimes you can even do anesthesia under local anesthesia or under IV toilet anesthesia or general anesthesia. And the difference is, typically when you do a septoplasty work, typically sometimes the blood can trickle back into the throat, and when people are awake, they can cough and things like that. And you sometimes can lose the control of the airway, because if there's some excess bleeding, there's hard to stay still. So whenever I do a septorhinoplasty, I have general anesthesia where there's a breathing tube in place, and everything is pretty much under 100% control. If I don't have to do any septal work and I just do a straightforward external rhinoplasty, sometimes I do it under local anesthesia, straight local anesthesia, which means that I inject the skin and we give them some gas to breathe while I'm injecting it in a couple of pills, and I can do almost all of the rhinoplasty under local anesthesia, where people are really truly awake. And some people tolerate it well, meaning they're not queasy about it, they're not anxious about it, they don't want anesthesia, they're more nervous about anesthesia than actually about the surgery. So in those cases, we offer patients local anesthesia to do a rhinoplasty. And if some people want a little deeper anesthesia, we give them twilight anesthesia through the IV, and we give it during the injection process so that they don't feel anything, because they don't want to feel that. And in that case, that's a very good alternative, because once the numbing medicine is in, we can really reduce the amount of IV medicine we give, and they are essentially awake, but they are very relaxed because they're getting some very small amount of anesthesia through the IV. So that's a twilight technique where they don't have a breathing tube. And if I do septal work where they have functional breathing trouble because there's septal deviation or crookedness, turbinate problems like I talked about, in that case, it's not safe, in my opinion, to do it under local or twilight anesthesia. In that instance, you have to, in my opinion, put people fully asleep with a breathing tube on the machine and make sure that they're not moving, and you have 100% control of their airway and their physiology so that you could really correct all of the functional problems. So septorhinoplasty is one of the hardest operations in plastic surgery. From my background as an ENT trained and also a plastic surgery trained surgeon, I love doing septorhinoplasty as well. I love doing facelifts. So all of these aspects I'm very, very comfortable with. So I have done a lot of septorhinoplasty work, a lot of reconstructive work, a lot of cancer work, and all these things that give you the versatility you need to do whatever is needed and not be very limited in what you do for noses. So I hope that's a good primer for you guys to understand the difference between rhinoplasty and septorhinoplasty, cosmetic work and functional work, and why almost always they go hand in hand together. Okay, thank you so much. Hope that helps you.